You see, I have a special. So, thank you very much, Mr. Chairman, for the kind introduction. It will be a little bit of repetition from what you have heard previously from Professor Bloquel, but the topic would be more on what we can do about a premature progesterone rise. Now, when we start stimulating women, there is one thing we neglect, and this is the fact that women are different. You know that the human reproduction is a very inefficient kind of reproduction. You know that women before birth have approximately 7 million eggs. The moment of birth, it's only 1 million. The moment of puberty, it goes down to around 400,000. And from these 300,000 to 400,000, you will only use 400. From these 400, more than half of them will be genetically abnormal. So you can see it's a very inefficient system, despite the fact it's 7 billion of us there. So it seems to work somehow. Now, you have seen this slide before. There can be up to 100-fold difference between same ages and the number of eggs. But when we speak about stimulation, we always want to have a certain number of eggs. And Christophe elaborated on that. What is the magic number? And I think we all agree that we don't want to have a poor response because the chances are very limited. We don't want to have a high response because there would be too much risk. So basically, there is a certain number of eggs we require in order to be successful. The question is, what is this magic number? Christophe mentioned maybe 15, maybe 18, maybe 21. But I think that's the wrong question. The question should be, how many eggs do we require, for what age of patient, and under which circumstances of stimulation? There is a difference if you stimulate and destroy completely the endocrine profiling. There is also a difference what kind of patient you are being stimulating. So some came out that we need to have 15. Then this is a study from Holland. So yeah, 14, 15, and after 14, 15, we seem to have a drop. But why do we have this drop? And do we have this drop with everyone? What about the stimulation pattern? What about the endocrine profiling? Now, as you can see, we publish other data demonstrating, no, actually, it doesn't seem to have a negative impact if you have more eggs. Again, how many eggs for whom? This is a beautiful study published about a year and a half ago from the States. So what they did, they said, look, based on various age categories, we want to know how many eggs you require to have yellow line, 1 child, 2 children, or 3 children. So let's say you are 30 years of age, which is considered very young in our field. If you have, let's say, 12 eggs, you have a chance of around 60% to be successful. If you have 28 or 30 eggs, it's 80%. So, or even more, 90%. But if you are, let's say, 41, which is considered old in the field of human reproduction, you see with the same number of eggs, you suddenly have half the result. Why is that? It's simply because the older you get, the more chromosomally abnormal embryos women do generate. So one thing is age, the other thing is the response of that particular patient. Now these differences, they can be of maternal, mostly they're of maternal origin. So we men are very lucky. Even if you are 70, 80 and we marry a young woman, we still can have healthy children. But women, they're not that lucky, unfortunately. You see that from the age of 35, 36, there is a significant increase of the mitotic, maternal-meiotic imbalance. So there are more and more chromosomal abnormalities which are coming from the maternal origin. Now, when we stimulate someone, obviously we want to recruit a certain number of eggs. You have seen the age of the patient, you have seen the number of eggs which would be required based on what kind of patient we are treating. So if you have a poor responder, what you want to recruit them all. If you have a normal responder, you want to recruit 70–80% of those follicles. And if you have a high responder, the last thing you want is to recruit all the follicles. So you want to recruit, let's say, 30–40% of those follicles. Again, when we speak about stimulation and recruiting of the follicles, the endocrine profile is absolutely mandatory to have a look at. Because a successful pregnancy is a pregnancy where you need to have a good embryo, preferably genetically normal embryo, and B, a receptive endometrium. Now, what is a receptive endometrium? Now, the receptive endometrium has been described, and today still we are referring to that very same paper, has been described to be a window of implantation, which we say LH plus 7 to LH plus 11. But is it really the truth that we have 5 days of receptive endometrium? Now, this paper has been published before the first IVF was conducted, obviously, 1973. So our knowledge there is extremely limited, because the window of implantation, the so-called window of implantation, is not 5 or 6 days. It's much more narrow than the 4 or 5 or 6 days which has been described. Today, if you do gene expression models, it's a matter of hours if your uterus or endometrium is receptive or it is not receptive. So basically, this is the endometrium that we are looking at. Now, what do physicians do? We try to simplify things. So the first thing we do, we perform an ultrasound scan, and mostly we have beautiful scans. We play with the buttons, and actually we say, uterus looks beautiful. It's great. But is it really great? Is really what you see what you get? No, because there is a lot of stuff behind that where we have no clue what's going on. So just having a look at the uterus or the endometrium is not sufficient to say that it is good. Now, the moment we start stimulating a patient, we change the endocrine profile. The moment you change the endocrine profile, you change the receptivity of the endometrium. And as you can see, if you compare a natural cycle with a stimulated cycle, all these cytokines, all these inflammatory parameters, which are important for embryo implantation, they change. So you cannot compare a natural cycle with a stimulated cycle. Very simple sentence. Now, from our previous group, Professor Bloquel's still current group, this paper came out many years ago. Every patient who is being stimulated has endometrial advancement. Every patient who is being stimulated has endometrial advancement. That's a fact. Now, these endometrial advancement, it can go by 1 day, 2 days, or sometimes more than 2 days. The question is, why is it relevant to have endometrial advancement 1 or 2 or 3 days? What does it mean? Very simple. These advancements of endometrium and embryo, it's like you have a puzzle. The embryo and the endometrium, they need to fit. If you have 1 or 2 days, somehow they will still fit. But if it goes beyond the 2 days, what will happen? The endometrium doesn't fit anymore, because then the gap is too big, which means that the pregnancy rates will drop because the endometrium is advanced and is becoming less receptive. Now, one of the factors which has been described previously by Christoph is the fact that actually progesterone starts to increase the bigger the size of follicles. So the bigger the follicles become, the more progesterone they produce. And this is a physiological fact. This is a physiological fact, that the bigger the follicles become, the more progesterone they produce. Good. In fact, before your LH rise, you have a tiny little bit of progesterone rise, which is pushing your LH to shoot up. Gene expression models have shown that actually this magic number of 1.5 nanogram per ml, that from this magic number, which I don't believe that, this is a paper we published together with Christoph, our previous group in Brussels, where we looked to gene expressions and we saw that there are significant differences between the gene expression of women with low progesterone and high progesterone. So you see there are more than 1,400 genes between high and low. And the same was done with Ernesto's group in Spain. So you see there is something happening in the endometrium. And as you have seen previously from Ernesto's paper, there is no doubt that the pregnancy rate is going down. There is no doubt about that. And this is independent of agonist or antagonist. It's going down. This is 60,000 cycles. Chris Venetis, who published, by the way, in 2007 a paper, again a meta-analysis. And actually, I am allergic to meta-analysis, but I'm going to present you these data. So, because the same person who is a good friend of us published in 2007 a meta-analysis saying high progesterone is not detrimental. A couple of years later, high progesterone is detrimental. So this is the value of meta-analysis. So I would be very cautious of looking into meta-analysis. But again, this is 60,000 cycles and confirming high progesterone is detrimental, point. Now, this is number needed to treat. And this paper demonstrates, okay, from which cutoff level onwards do we have to do something about it? And as you can see, from here somewhere, 1.3, 1.4, 1.5, the number needed to treat for have one more live birth, the green line, goes down. It means basically if your progesterone is around 2 nanogram per ml, if you treat 2 patients, you have 1 more pregnancy. It's very simple. It means if you go above this cutoff value, you need to do something about the high progesterone value. Of course, you could start arguing, as we did previously, on what about the inter-assay variation, what about the intra-assay variation, what about the day and night rhythm of progesterone. I fully agree with you. There are variations. And this 1.5 is not the golden crown to say, wow, that's what we have to look at. But at some point, you need to put a certain cutoff limit. This is the paper I was referring up, the day and night rhythm, live bungum. There is a significant difference if you measure morning or evening. And as you have heard previously, we did a similar study like Nikos, and we measured day and night, and we saw 70% also differences between day and night in a stimulated cycle, but vice versa. So you see, this is also based on the time of your FSH administration and the length after the FSH administration when you're going to start your progesterone measurement. So the time of measurement is extremely important. This is a paper we published last year with our group in Abu Dhabi, where we looked to the assay variations from the same company, second and third generation. I emailed Ernesto, I told him, look, you remember, we just changed from second to third generation, and I see some differences, especially in lower values. And if you go to lower values with the same company, it's the same company, Roche, we had huge differences, huge differences. So this is why taking a cutoff level, saying, look, that is it, I think we passed that stage. We have to go further, and every clinic has to find out what is the best cutoff level for that particular clinic. Now, this decrease of pregnancy, independent of age, independent of blastocyst quality, and independent on number of oocytes retrieved. So if you stratify according to any factor you want, I think you all see clearly there is a drop of the pregnancy rates. Now, even if you compare blastocyst cleavage stage, it's the same. Because at some point, our common friend Papa Nicolau published a paper in FNS where he described basically with blastocyst, you don't have a negative impact if you have high progesterone. But also that, as you can see here, seems not to be fully correct. For those among you who like natural killer cells, also there seems to be an impact on the natural killer cells. Now, embryo quality, you have seen from Christophe, also there is a decrease on embryo quality, day 2, 3, also day 5, 6. So all that has been recently published, because up to 2 years ago, you would have said, I have a good lab. I rely on my embryologist. I'm going to vitrify everything, and I don't care about the endometrium. I'm going to put them back in a subsequent frozen cycle. Is that the solution? No. Because also, if you freeze, you seem to have a negative impact on your oocyte and embryo quality. As you can see, Christophe's group with Annelisa Racca published this paper last year in Human Reproduction, where they also described a cumulative decrease on embryo quality. Now, we know that actually everything in the uterus is controlled by steroids. Now we need to go back to basics to understand Why is progesterone increasing? Why do some patients have an increase of progesterone? Now, this question has initially been asked, and the prevalence has been described to be up to 25, sometimes 30%, which is a lot. So if you see that high progesterone is jeopardizing the outcome, the next question would be, is it feasible to prevent this of happening? You have delta 4 and delta 5 pathway. So you have your cholesterol, which is basically convert to estradiol, and this is a unidirectional pathway. So it's only one way. You cannot go back anymore. Now, have a look at this slide. I think this is a very important slide. You see that there are several enzymes here which are responsible for these conversions. Now imagine you have a factory, not in Hungary, the factory is in China. You produce something. You produce shoes, let's say. And you put a lot of Chinese workers there, you tell them, produce. This factory is producing, but you make a lot of money, so you want to produce more. So you tell them, look, more, more, more. You push them, push them, push them. Until some level, you will produce more and more of what you want. But if you start pushing too much, what's going to happen? It will backfire. Because they will not be able to do more than what they are doing. So they will try to find a way, so the quality of your product will go down. So instead of going that way, because they cannot produce more of this, they will start producing more of this. It's like there is no other way. I'm pushing too much, so I'm going to look and try to find something different. And this is the concept which we had from the beginning, why progesterone is going up during the stimulated cycles. Now, at some point, studies came out, also Johann Smits was involved in them, said, look, maybe with the ACG activity or LH activity, we will prevent this of happening. And at some point, there were some points towards, yes, maybe we can prevent this of happening. The only problem is the bigger the follicles become, the more progesterone they produce. So in that study, this group of patients was triggered at a significantly bigger size follicles. So there was a little bit of bias here. And also others have said, look, maybe you need to have a kind of LH and FSH ratio, which I don't believe, because this is again a big group with a huge heterogeneity in that group. Same group looked as Johan presented, no ACG, 50 units, 100 and 150 units of ACG. But at the end, those patients, the more ACG they had, the higher was the progesterone. So this is not the solution. So if you want to reduce progesterone, I think we need to understand better the cause of it. Why is progesterone going up? Now, if you go back to the theory that maybe too much pressure is the cause of it, then we need to understand maybe there is a way to reduce the pressure on these follicles. Now, this is a study published by Paul Defruy comparing the progesterone values between different stimulation protocols. And if you trigger the same size, there seems to be no significant difference. Also, if you add recombinant LH, that doesn't reduce your progesterone production. In fact, LH receptor gene expression is responsible for progesterone production. So LH, you know, in the luteal phase, you need to have LH to produce a progesterone, basic knowledge. So LH is actually responsible for progesterone. And the higher your LH levels, the more is your progesterone levels. So LH is not preventing progesterone production. So we started saying, looking back and trying to reinvent the wheel. As you mentioned previously, very often we forget very old studies. Beautiful studies were conducted, and we don't know them. We don't read them, and we try to do again the same mistakes. So we went back and said, hey, it seems to be somehow related with high estradiol and high number of oocytes. So with Dimitra Kirou, who was working with us in Brussels at that time, we tried to find out what kind of patients are at risk to have a high progesterone. And it came out, in fact, if you have patients where you have estradiol levels which are high, where you have a high number of follicles, 12 follicles more than 11 millimeters, then you would be at risk to develop high progesterone. So we already had a hint, maybe we are pushing too much. And maybe if you push towards the end of the stimulation of the follicular phase, this is happening. Now, I always try to learn from nature. If you take a look at nature, the FSH goes up beginning of the follicular phase, but towards the end of the follicular phase, your FSH goes down. But what do we do during ovarian stimulation? We push, we push, we push, we push, we push until the last day. Maybe this is not the correct way. Maybe we are pushing a little bit too much with some patients. Maybe the factory of some patients is not supporting too much pressure as we are administering. An issue, this is another, I think this is the second important, most important slide of my presentation. Progesterone itself is not detrimental. So the progesterone 1.4 or 1.5 or 1.3, 1.6 is not detrimental. Progesterone is the light in your car going on that something is cooking, something is happening. The engine light goes on, that there is a problem. So the progesterone is an indicator for us. It's not the bad guy. Progesterone is showing us something is happening. We know that the more FSH you administer, the more LH receptors we generate. And the more LH receptors you have, the faster will be your final oocyte maturation after triggering. And then the next question would be, if you have too many LH receptors, would there be a difference in the rise of progesterone if you trigger with an agonist as compared with ACG? And the answer is yes. There is a paper coming out from Peter Humeidan where they looked exactly on that topic. I think the paper is not out yet, but it will be out shortly with Klaus Eding Andersen, where they looked exactly to that factor. High progesterone, low progesterone, triggering with agonist or triggering with ACG, and seeing that there is a different pattern of progesterone rise. The faster your progesterone rises, the faster is your final maturation, and the faster is your endometrial advancement. Now, this concept that you push too much is the cause of high progesterone has been confirmed from a Turkish group, I think 2 years ago now. And as you can see, too much pressure, pressure, pressure. At some point, this is accumulated, and it's entering into the systemic circulation. Now, as I mentioned to you, what we do on a daily basis, we stimulate, 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 and we continue doing so on a daily basis until we do the trigger shot. So what we did, we looked in patients who have been stimulated with choline alpha. So there is a high level of stimulation the first 2 to 3 days. And the last couple of days, there is a step down. So we wanted to know if this high stimulation and step down has an impact on progesterone levels. Because if our theory would be correct, we would see significantly lower progesterone levels with these patients. And this we published about 2.5 years ago in Human Reproduction, where we saw, yes, if you do this step down, you almost have 0 patients who have high progesterone. But if you don't do the step down and you continue, you will have high levels of progesterone. Of course, we also stratified according to the number of eggs, and this was the truth in all patients. So it seems that there is a direct correlation between the pattern of how hard we are stimulating. Now, if you take a look at this graph, we published this more recent data last year at ESHRE, where we said, look, if this theory is correct, in the beginning, we are exposing a lot of FSH. At the end, we give less FSH. What happens here? Because if you have too much FSH, also here, your progesterone should be higher. And indeed, if you take a look at day 5, you have more FSH. So you see progesterone is higher. Day 1 is the same. Day 5 is higher, but day 8 is lower. So you go from high to low. So there is a direct correlation between your FSH and your progesterone value. So we measured on various points, and as you can see, in all groups, it was the same. It's purely because of too much FSH being administered. And at the end, it seems that especially the last 2-3 days of stimulation, per 50 units of FSH you administer, you significantly increase the risk of progesterone rise. Also, prolongation of stimulation is important. It's a paper we published, I think, also a year ago. Yes, a year ago, where we looked into the length of stimulation, and also here it seems to be also one of the causes of high progesterone. If you are interested in that topic, we published a couple of papers also with Ernesto, a paper in FNS a couple of months ago, where we describe actually this phenomena and how it is feasible to prevent it of happening. And yes, it is feasible. So today, I can tell you, we barely see or never see high progesterone because you can control and you can prevent it. So I think we can conclude. The moment we start stimulating someone, we change the endocrine profile, we change the endometrium. Implantation, a window of implantation, is a very complex process. And actually, the endocrine profiling, especially progesterone, has an impact on endometrium and a possible impact on egg and embryo quality. High serum progesterone, as has been published on many occasions currently, has an impact on the outcome. It decreases the outcome in fresh and possibly also in subsequent cumulative pregnancy rates. It's not depending on what you use. When you stimulate with FSH, what kind of FSH you also use, it is very important that towards the end of the follicular phase, based on the endocrine profiling of that patient, you do not continue pushing too much. Because if you do so, some patients, the factory will explode, and then you will have this high progesterone as you have seen. I think IVF treatment today, it is going more and more towards individualization and more away from meta-analysis. Because this is what individualization means. Individualization means initiation dose and adaptation dose. Thank you very much for your attention.